Cranial nerve 1 is the olfactory nerve. It is a sensory nerve that carries the sense of smell to the brain. Lesion of the olfactory nerve may lead to anosmia, which means total loss of sensation of smell. It can be assessed by asking a patient to smell familiar substances like coffee, etc. To test the functions of the cranial nerve 1, the patient is asked to smell certain familiar substances with her eyes closed, one nostril at a time. For a patient with normal functions, the patient will be able to identify the substances without any difficulty. The cranial nerve 2 is the optic nerve. It is a sensory nerve. It carries the sense of vision to the brain. A lesion in the visual pathway may result in either total loss of vision or loss of a specific part of the visual field. Test for the optic nerve can be remembered by the mnemonic AFRO, where A stands for acuity, F for field of vision, R for reflexes, and O for ophthalmoscopy. For the first part, the patient is asked to read letters from a chart placed roughly 6 meters away. First, the patient is asked to cover his left eye and is asked to read. After that, the patient is asked to cover the right eye and then asked to read. To test the patient's field of vision, place your hands outside the patient's field of vision and then bring them in front quickly. If the patient blinks, it indicates that the patient has a good temporal vision. To test the visual reflex, take your finger close to the patient's nose and observe his pupils constrict. For the test of ophthalmoscopy, point a bright light into the patient's pupil and observe the pupillary constrictions one by one in both the eyes. For a patient with normal pupillary reflex, indicates that there is no problems with the CN2. The cranial nerve 3 is the oculomotor nerve. It is entirely motor in function. It controls the constriction of the pupils, movement of the eyelids, shape of the lens, etc. The cranial nerve 4 is the trochlear nerve. It is entirely motor in function. It controls the movement of the eyes. A lesion in the trochlear nerve results in weakness of downward eye movement with consequent vertical diplopia. The cranial nerve 6 is the abducens nerve. It is mostly motor in function. It supplies the lateral rectus muscle of the eye, which is responsible for outward gaze. The tests for the cranial nerves 3, 4 and 6 are performed as follows. First, observe the patient's face for any deviation of his eyes. Then, ask the patient to follow your finger as you make an H-shaped pattern. For the next test, ask the patient to follow your finger as you bring your finger close to the patient's nose. For a patient with no defects in the cranial nerves 3, 4 and 6, the results would be that the patient's eyes converge and the pupils constrict as your finger goes closer to his nose. The cranial nerve 5 is the trigeminal nerve. It is both sensory and motor in function. The trigeminal nerve innervates the muscles of mastication and gives sensory output from parts of the face, head and neck. To test the integrity of the cranial nerve 5, the doctor first observes the patient's face for any visible signs of muscle wasting. The doctor then asks the patient to clench his or her teeth while the doctor palpates for the muscles of mastication. The doctor then uses a sharp object to prick the patient's face at various points while the patient gives the doctor a feedback whether he or she is feeling it or not. The doctor then uses a cotton ball to test the corneal reflex. The cranial nerve 7 is the facial nerve. It emerges from the brainstem between the pons and the medulla. It controls the muscles of facial expression and functions in conveying the sensation of taste from the anterior two-thirds of the tongue. A damage to this nerve may lead to the paralysis of various facial muscles or may lead to conditions such as Bell's palsy. When assessing the integrity of the facial nerve, the first thing to notice is any drooping in the face of the patient. The second thing to notice is when the patient looks upwards, the doctor tries to notice any uneven creases on the forehead. For the next test, the patient shuts his eyes tightly while the doctor tries to open them. If the patient is able to resist, the facial nerve is in good condition. Patients with facial nerve palsy show certain other symptoms such as an uneven smirk. Patients with this problem also are unable to drink water without spilling it. The eighth cranial nerve is the vestibulocochlear nerve. The vestibulocochlear nerve is responsible for the sense of hearing and also pertinent to balance and body position. For the cranial nerve 8, the first test is the René's test. In this test, the doctor uses a vibrating tuning fork to compare the bone conduction with the air conduction. For a patient with normal hearing, the air conduction is more sensitive than the bone conduction. The second test is the Weber's test. In this, the doctor compares the sensitivity of both the ears by placing a tuning fork in the middle of the forehead. The normal response for this test would be that the patient hears the sound equally in both ears. For the vestibular component of the auditory nerve, the doctor asks the patient to close his or her eyes and march on a particular spot. For a pathological patient, the patient tilt towards the side of the lesion. The cranial nerve 9 is the glossopharyngeal nerve. It is both sensory and motor in function. It receives sensory information from the tonsils, pharynx, middle ear, and posterior one-third of the tongue. The cranial nerve 10 is the vagus nerve. The vagus nerve supplies motor parasympathetic fibers to all organs except for the adrenal glands below the neck. For the cranial nerves 9 and 10, the doctor asks the patient to open his mouth and depresses his tongue in order to access the uvula and soft palate. The doctor observes any asymmetry in the uvula and soft palate indicating a defect with the cranial nerves 9 and 10. The doctor then asks the patient to cough and drink some water. Any kind of delay in swallowing or coughing indicates a damage to cranial nerves 9 and 10. The cranial nerve 11 is the accessory nerve. It is mostly motor in function. It provides innervation to the sternocleidomastoid and the trapezius muscles. For the cranial nerve 11, the doctor asks the patient to elevate his shoulders and resist while the doctor tries to depress them. The cranial nerve 12 is the hypoglossal nerve. It is solely motor in function. It provides motor innervation to the muscles of the tongue except for the palatoglossus muscle. To test the hypoglossal nerve, the doctor asks the patient to force her tongue against the cheeks while the doctor checks for resistance. For the next test, the doctor asks the patient to stick her tongue out while the doctor checks for any lateral deviation or muscular atrophy. For the next test, the doctor asks the patient to move the tongue from side to side while the doctor checks for any abnormalities in movement. We humans have the ability to interact with the world around us using our upper limbs. Precise motor maps created in our brain enable us to move specific muscle groups in a discrete way that helps us perform various activities such as playing different sports. These require precise muscle movement and precise control over those muscles. But what makes these discrete movements of the upper limb possible? We are now going to explore the formation of the brachial plexus, the nerve bundles that make this unique human experience possible. The brachial plexus originates from the roots C5, C6, C7, C8 and T1. It has both motor and sensory functions. It has three distinct trunks. The superior trunk is formed by the C5 and C6. The middle trunk is the continuation of the C7, while the inferior trunk is formed from the C8 and T1. These trunks have anterior and posterior divisions so that all roots supply multiple organs, while most organs are also supplied by multiple roots. The anterior division of the superior trunk and the middle trunk form the lateral cord. The posterior division of all the three trunks forms the posterior cord. The anterior division of the inferior trunk continues as the medial cord. The medial cord not only forms the ulnar nerve but also the medial part of the median nerve. The lateral cord forms the musculocutaneous nerve and the lateral part of the median nerve. Damage to the axillary nerve can happen when somebody falls on the shoulder, damaging the neck of the humerus. This causes damage to the axillary nerve and the patient is unable to abduct the hand above 15 degrees. Damage to the wrist may lead to a condition known as carpal tunnel syndrome, which may result to compression of the median nerve, causing a condition known as ape hand. Care should be taken while performing activities such as the handstand because injuries might happen, damaging the musculocutaneous nerve, causing loss of sensation in the forearm and weakness in the shoulder. Damage to the radial nerve might occur when there's any kind of damage such as a stab wound along the path of the radius, such as the radial groove of the humerus. Such kind of injuries results in a condition known as wrist drop. The ulnar nerve might get damaged when a person falls on his or her elbow. This might result in condition called cubital tunnel syndrome. The symptoms of ulnar nerve palsy include pain, weakness of grip, loss of sensation in the ring and little finger.
Hi, I'm Kathy. I'm 23 years old. Before, I had never had headaches, but now I cry every time out of pain. My headache severe when I sit or stand up. It relieves when I lie on bed, but that's not possible for me. I have to attend my classes. I have so many exams, day after another. I visited a doctor. He diagnosed me with migraine and gave me so many medicines. Months gone, nothing happened. I didn't get relief. So I visited the doctor again and they told me for a MRI scan. After that, they told me that I have a spinal leak. When I asked what was that fluid leaking from my body, they told me everything about it. The fluid is called cerebrospinal fluid and it bathes all the brain and spinal cord. It has many protective functions and it cushions the brain. It is found in the ventricles of the brain and the subarachnoid space of the spinal cord. Now everything is fine. I'm studying for my exams and hopefully I perform well in them. Now where does this CSF come from?
CSF is produced in choroid plexus of the ventricles that are lined with special types of cells called ependymal cells.
What are these ventricles and how can CSF reach from brain to spinal cord?
Ventricles are four fluid-filled cavities located within the brain. The four ventricles are the two lateral ventricles present in each cerebral hemisphere. They are roughly C-shaped cavity that has a body and the three horns that extend into the different lobes of hemisphere. The anterior horn extending to frontal lobe, posterior horn to occipital lobe, and inferior horn to temporal lobe.
From the lateral ventricle through the interventricular foramen, it goes to the third ventricle. The third ventricle is a slit-like cleft between the two thalami. The third ventricle then contacts with the fourth ventricle through the cerebral aqueduct of Sylvius. The cerebral aqueduct is a narrow channel that connects the two ventricles that are the third and the fourth ventricle. The fourth ventricle is a tent-shaped cavity posterior to the pons and medulla and anterior to the cerebellum. In the inferior medulla, the fourth ventricle tapers off into a central canal. That central canal is continuous in the spinal cord. The subarachnoid space is the interval between the meningeal layers of the brain and the spinal cord, mainly the arachnoid and the pia mater. The cerebrospinal fluid flows in this space. Summarizing the circulation of the cerebrospinal fluid. The circulation begins with its secretion from the choroid plexuses in the ventricle. The fluid passes from the lateral ventricles into the third ventricle through the interventricular foramen and then to the fourth ventricle through the cerebral aqueduct. After entering into the fourth ventricle through the cerebral aqueduct, the CSF continues to flow into the spinal cord through the central canal. It may also enter to the subarachnoid space through the three foramina in the medulla.